We'll move on to our next speaker. So Dr Yoshiro Okubo obtained his PhD from the University of Tsukuba in Japan, where he investigated the influence walking had on falls in seniors. He was awarded the Graduate School of Comprehensive Human Sciences Chair Award from the university and a postdoctoral fellowship for research abroad by the Japan Society for the Promotion of Science, which they might regret because he seems to have been here for a little while since then. And so Dr Okubo is now part of the Falls Balance and Injury Research Centre at Neura, where his research is focusing on helping people to better learn to respond to trips and slips and to prevent falls. So he's going to be telling us about reactive balance training from research to practice. So welcome, Yoshi.
Thank you, Kathy, for the kind introduction. That was a long time ago, and I have been in Australia for 10 years now. Okay, so I think many of you had experienced at least one trip in the past 3 months. That's a lot of very common event in older adults. So research shows that most older adults experience trips in every 3 months. But the key is that you need to have a good reactive balance to respond to those trips to regain balance, to prevent falls in such situations. So in Australia, 130,000 fall-related hospitalizations occur each year, but the vast majority, the 30%, are a result of trips, slips, and stumbles. And this is a sort of a gap in the traditional exercise approach that they couldn't really address these sudden events, how to prevent falls when trips and slips happened. So that's what we try to address. Which way should I? Okay, so reactive balance training is our focus today, and the definition is that it's a type of balance training that involves repeated externally applied mechanical perturbations, specifically designed to trigger rapid automatic reactions to regain postural stability. So conventional balance training generally try to maintain postural stability, but reactive balance training intentionally cause loss of balance and practice how to regain postural stability. So there are two basic key criteria that you need for reactive balance training. First is that you have to have external perturbations. So if you start using internal perturbation, because internal perturbation happens every time that you walk and stand, it's kind of become a little bit into a traditional balance training. So we want to give external perturbations. And the second is that that perturbation has to be sufficient magnitude to cause a loss of balance, so that if you don't react enough, then you will fall into the harness. So that's the reactive balance training. So there are so many different types of reactive balance training, and we don't know which one is most effective. And at the beginning, so we have to decide, okay, what activity you want to do before the perturbation can be standing, sitting, or sit to stand, or walking. And there are so many different types of perturbations that you can give, either through the treadmill, the belt can rapidly accelerate or decelerate using a perturbation treadmill, or cable pulling of the ankles or the hip. And an overground system, you could use a pop-up systems or cable poles or slippery material. And manual perturbation is very becoming common in clinical practice. You can use push, pull, and lean and release technique, which I'm going to show you later. But what's really important is that what kind of reaction that you want to elicit, and that's essentially what we're going to train using the perturbation reactive balance training. So our focus is stepping in forward and sideways directions, And if you give predictable perturbations, then patients learn to predict what's going to happen next. So if you do unpredictable perturbations, you're more likely to train the reactive balance. Okay, so this is a YouTube video that was produced a few years ago now. So we developed a trip and slip walkway. A trip and slip can happen anywhere on this 8-meter walkway. And the participant, of course, is wearing a safety harness. So they can safely practice how to optimize their reactive balance in the case of trip and slip. So this tile can move anywhere on this walkway. And in a single training session, participants are generally exposed to 20 trips and 20 slips, and they get to practice. So that's a very rare event in daily life. It's very difficult to practice, so we developed this walkway. So we had a study, safe trip study, which was mostly run by Stephen here and also Kali in the audience. We had 111 older participants randomized into control group and intervention group. And the intervention group had only 3 training sessions in 3 weeks. And each training sessions had about 20 trips and 20 slips. And after that, so we had 3 monthly retraining sessions, like a booster shot, to make sure that you remember what you learned. And we had falls monitoring weekly using SMS survey, so they can report to us whether they had falls and trips and slips in their daily life. So this is the result. So the falls, overall falls for 1 year didn't reach statistical significance. But if you look at the quarter 1, the first three months, there was significant 60% reduction in the number of falls. After that first 3 months, the reduction in falls didn't become significant anymore. So our retraining session may not be sufficient at the time, but we did have COVID-19 and 2 big lockdowns, so the retraining schedule were very messed up at the time. If you look at the cause-specific falls, trip falls and slip falls tend to reduce, and the slip falls tend to reduce a little bit more. We looked at trip encounters in daily life and slip encounters, and actually there seems to be some increase in the incidence of tripping and slipping. And at the end, we had 50% reduction in injurious falls for the 12 months. So this is Stephen's PhD work, and we looked at the adaptation, short-term adaptation between training 1, pre and post, at the beginning, at the end of the training 1, and third training session, especially looking at the co-contraction of the muscles around the ankle. So we want to reduce the co-contraction in order to do the efficient, quick recovery movement. So at the end of the third training session, the co-contraction reduced significantly. And then when they came back for the retraining session at month 3, there was a little bit of diminishing effect. But within that one retraining session, they actually got back to the post-training level of adaptation. And then at 12 months reassessment, they also had, it's not statistically significant, unfortunately, but reduced co-contraction. And then on the right side, you have the harness loading. So if you had a big fall into the harness, there is greater harness loading. So we want to reduce that. We basically show similar trend of short-term adaptation, and then at 3 months, a little bit of reduced effect, but you can reactivate through the retraining. So this was our hypothesis before we ran this study, that reactive balance training could potentially reduce fall through improved postural responses, which we kind of proved through the electromyography data and also kinematic data. And the data from the daily life falls also indicated that they actually had improved recovery in daily life events. We also had another hypothesis that possibly cognitive behavioral pathway would play a role, because many people say, well, after this training, I became more aware of where to place my feet. But it didn't show that trend in our data, as a participant actually did increase trips and slip a little bit. Okay, so that training program using the long walkway is definitely not practical for clinical settings, so we wanted to make reactive balance training more accessible, and we developed this Reactive program. So basically using the tether release technique, participant lean against the tether in forward, backward, and sideways direction, and that tether is suddenly released, and now you have to take a rapid recovery step to regain your balance. And we could also add cognitive challenge. And we also had volitional slip training, the participant repeatedly stepping onto a slippery plastic sheet to learn how to control your balance while your base of support is now slipping. And we also added home-based strength training to add extra strengthening of their lower limb muscles. So there's a little video. So we had 6 training sessions over 6 weeks, and the results shows that they definitely improved the reactive balance skill using the tether release. So the tether loading is the maximum loading before the release, and they have to regain balance in one step. So that loading increased significantly in all directions, so that was very good. We also saw a significant improvement in usual gait speed, maximum step length, and step reaction time in the intervention group. So that was really good. However, if you look at the transfer to unexpected trip and slip, so we wanted to see if they can actually recover really well from this unexpected trip and slip. And unfortunately, it didn't really transfer well. So that individual had a fall into the harness after the slip. And this time, the recovery from trip was successful. But overall, there was no significant reduction in rate of falls from those laboratory-induced trips and slips compared to the control group. So this is sort of my learning from these 2 studies. So what is the optimal reactive balance training method? So we use the trip and slip walkway, which has very high task specificity, and we show the efficacy. But when we want to make it clinically applicable with low-cost equipment, in the case of reactive step training, there seems to be a little gap in the transfer. So we want to find the ideal method. It can be definitely low cost and accessible, but probably we need to think a little bit more about how to make it task and context specific to the falls in daily life. Okay, so take-home messages. So reactive balance training targets postural reactions to react to real-life perturbations such as trips and slips. And reactive balance training can be delivered in low dose. So we had only 3 sessions and 3 months retraining sessions, and has been shown to reduce falls and fall-related injuries in older people. Motor adaptations gained through this training may diminish around 3 months, but can be reactivated through booster sessions. And reactive balance training can be implemented using low-cost method, but this should be carefully designed to promote real-world transfer to prevent falls. So more research is needed so that we can translate reactive balance training into clinical practice. So I'd like to thank everyone who was involved in this study, and thank you for listening.
Thanks so much, that's great. We've got time for a couple of questions. Maybe stand up or wave if you want to make a question. Here's one. Dr. Taylor here.
Yoshi, in the intervention group where they had more falls and trip occurrence, like, what was it, interactions, how much do you think that is because they've been trained to identify them through the training?
Definitely that they were more aware of trips and slips, so more diligent reporting possibly could happen, but didn't lead to more diligent reporting in falls and fall injuries, so that was promising.
Excellent. Any other questions in the room? And just remind people online to put the questions on the Slido. We've got a question up the back.
I'm just curious to know why you selected that in the first place. Just with such little dosage?
So reactive balance training is really practicing how to respond to that specific perturbation. So we know that it doesn't improve physical function, it doesn't improve muscle strength, but you improve how to respond and how to possibly predict as well. So that can happen in a different pathway compared to traditional exercise progression.
Excellent. And we've got a very politely worded question on the Slido asking about basically adverse events during the training and how that was managed.
Yes. So this safe trip study involving the walkway trip. So we had a few adverse events, so mostly strain the muscles in the very first trip and slip, which was intended to be the assessment, which was required for our research purpose, that we wanted to see their response at their usual gait speed and consistently walking at the same pace. But during the training, the walking speed can be reduced and the intensity of the trip and slip can be reduced. So halfway through the study, we actually removed those assessments that was happening together with the training session, and after that, we didn't see adverse events.
Excellent. And we'll just take one last question from online, and people in the room can try and catch Yoshi at lunchtime, about any information on concerns about falling and the training.
We did have data on concern about falling using the International Falls Efficacy Scale. It didn't change in the intervention group. And there was apprehension definitely reported by many older adults, and we have to manage the apprehension through frequently asking their level of anxiety, and then that informed the training progression.
Excellent. Thank you very much. And then we've got the gift and a certificate for you and another photo, and well, thank you very much for your excellent presentation.